Hi everyone, my name is Rodelle Ann De Vera and my scholarly project's title is a Quality Improvement Project Implementing an Algorithm for Acute Bronchitis Management. My chair is Dr. Heather Deering, second reader is Dr. Maria Snell, and community member is Dr. Rugan Singh. Let's start off with the background. Antibiotic resistance has become a significant public health threat, responsible for approximately 1.27 million deaths worldwide in 2019 and contributing to 4.95 million deaths overall. Deaths related to antibiotic resistance could continue to rise, potentially reaching to 1.91 million by 2050, representing a 70% annual increase compared to 2022. Global deaths could reach 39 million deaths between 2025 and 2050, which is equivalent to 3 deaths per minute. Acute bronchitis is an inflammation of the large and mid-sized airways, most commonly caused by viral infections. It is a self-limiting condition, and its treatment primarily consists of symptomatic and supportive therapy. Acute bronchitis is a major cause of inappropriate antibiotic prescriptions in outpatient settings. Antibiotics are prescribed in 60 to 90% of acute bronchitis cases in the United States and worldwide, contributing to the development of antibiotic resistance. Outpatient settings such as urgent care centers and primary care clinics is the leading source of antibiotic overuse, with approximately 30% prescription being unnecessary. Moving on to my clinical question, this is my PICO. Population, clinician in outpatient settings. This includes nurse practitioners, physicians, medical directors, medical intervention, implementing an evidence-based algorithm, comparison, compare pre and post implementation data, outcome, reduced rate of antibiotic prescription for acute bronchitis, and time frame is over a 6 weeks period. The scholarly project aims to implement an evidence-based guideline to reduce antibiotic prescription rates for management of acute bronchitis, to evaluate the effectiveness of the tool in reducing antibiotic prescription rates for acute bronchitis, to educate clinicians on the importance of antibiotic stewardship, and lastly, promote appropriate antibiotic use. Moving on to review of the literature. Study shows that an increase in the clinical decision support system, CDSS, is associated with a reduction in the likelihood of patients receiving antibiotics. Gonzalez et al. Examined the effects of implementing printed and computer-assisted decision support strategies for treating uncomplicated acute bronchitis. The results indicated that the antibiotic prescribing rates decreased from 80% to 68.3% with the printed CDSS tools, and from 74% to 60.7% with computer-assisted CDSS tools. Multiple studies have found that education interventions focused on appropriate antibiotic use consistently led to a reduction in unnecessary antibiotics. Lang et al. Evaluated the effect of interactive educational sessions on nurse practitioners and physician assistants in urgent care settings. This intervention significantly reduced antibiotic prescriptions for acute bronchitis from 91.7% to 29.8%. The literature also highlights the patient demand and expectation as a significant contributor to antibiotic overuse. Studies show that clinicians feel pressured to prescribe antibiotics due to perceived patient expectations even when they are not indicated. Healthcare providers stated that many patients sought immediate relief and demanded antibiotics. In some cases, patients expressed dissatisfaction or even threatened to seek care elsewhere when denied antibiotics. The clinical setting and situational factors such as time constraint and time pressure often influence clinicians' prescribing decisions. A study reported that limited time with patients hindered participation in thorough discussions, including educating patients on the differences between viral and bacterial infection, appropriate follow-up, and evidence-based management. Due to time pressure, patient education was often shortened or overlooked entirely. Similarly, other studies noted a lack of time to review clinical guidelines as a contributing factor, especially in busy clinics with high patient volumes. Poor communication between patients and providers contributes to antibiotic overuse. However, studies show that communication-focused training programs such as using patient scenarios, expert-led education, appropriate terminology, using chest cold instead of bronchitis can reduce patient expectation for antibiotics. I have a picture here of the Iowa model of evidence-based practice. I chose the Iowa model of evidence-based practice as my theoretical framework because it aligns closely with the goals of this project in promoting high-quality patient care. This model was selected because it emphasizes the use and translation of relevant literature and research findings into clinical practice to improve patient outcomes. This model consists of 7 phases. The first phase of the IO model is identifying the practice, problem, or issues. The second phase is stating the question or purpose. The third phase is forming a team. The third phase is forming a team. The fourth phase is assembling, appraising, and synthesizing body of evidence. The fifth phase is designing, piloting evidence-based intervention. The sixth phase is integrating and sustaining a practice change, and the seventh phase is disseminate results. Okay. The model structured the project, my scholarly project, by first identifying the problem of antibiotic overuse and resistance, followed by defining the purpose of implementing an evidence-based guideline, educating providers on appropriate prescribing practices, and antibiotic stewardship in outpatient settings. An interdisciplinary team was involved and current evidence was reviewed to support effective interventions. The project included implementing an acute bronchitis algorithm with an emphasis on sustaining practice change. Lastly, results will be shared with colleagues and faculties to promote ongoing use of evidence-based practice. Moving on to methods and design. This QI initiative utilizes a quantitative retrospective design to analyze patient charts via the clinic's electronic health record, or EHR. The rationale for choosing a retrospective approach is that this will determine whether implementing an acute bronchitis algorithm will be effective in improving antibiotic prescription rates and to evaluate if it's statistically significant. Clinician education was given 2 weeks to review educational materials in the form of PowerPoint slides. Data collection tool was developed following an extensive review of literature and national guidelines. The data were extracted from the electronic health record of patients scheduled from October 2, 2025 to November 12, 2025. October 2, 2025 to November 12, 2025, which is the pre-intervention or pre-implementation phase, and November 13, 2025 through December 25 to 2025 for the post-implementation phase. This is a total of 6-week intervention period. Each chart was de-identified and assigned a numerical value. Collected data were stored on a password-protected computer and kept in an office accessible only by the author. Data were processed and analyzed to determine the impact of an algorithm on acute bronchitis management with the assistance of Maryville University's statistician Dr. Pauls. Moving on to the sample. The recommended sample size for this project is 154 charts from the clinic's EHR. The sample size consisted of a total of 69 charts, 40 charts from the implementation phase and 29 charts from the post-implementation phase. The patients were divided into two groups based on the dates. Pre-intervention, again, October 2, 2025 through November 12, 2025, and the post-intervention is November 13, 2025 to December 25, 2025. Inclusion and exclusion criteria were applied, and this is an example of my criteria. The inclusion criteria for the EHR to be included in the data collection process are the following. The patient is 18 years of age or older. The patient may be male, female, or non-specified gender. The patient may be of any ethnicity or nationality. The EHR had a documentation that the patient was seen at the clinic between October 2, 2025 through December 25, 2025. The EHR documented that the patient had an acute bronchitis or had a documented that the patient had a diagnosis code of J20.9. And the EHR was signed and closed. Exclusion criteria for the EHR to be excluded in the data collection process are the following. The patient is 18 years of age or younger. The EHR will be closed and no data will be retrieved. The EHR had a documentation that the patient was not seen at the clinic between October 2, 2025 through December 25, 2025. The EHR had no documentation of acute bronchitis. The EHR will be closed and no data will be retrieved. Or the EHR had no documentation of a diagnosis code of J20.9. The EHR will be closed and no data will be retrieved. The EHR chart was incomplete, meaning it wasn't signed or the chart was kept open. The EHR will be closed and no data will be retrieved. And lastly, the EHR documented that the patient has an exacerbation of chronic obstructive pulmonary disease or COPD. The EHR will be closed and no data will be retrieved. Moving on to data analysis. The data collected was to evaluate the effectiveness of an algorithm in reducing antibiotic prescription rates for acute bronchitis. It was analyzed using a lower tail z-test for the difference of two proportion, a directional form of the chi-square test with a significance level of 0.05. This test was used to determine if there was a statistically significant difference between the rate of antibiotic prescriptions for acute bronchitis before and after the implementation of the acute bronchitis algorithm. Moving on to results. In the pre-implementation phase, 19 out of 29 or 65.5% charts did not include antibiotics as part of the management for acute bronchitis despite the absence of an antibiotic guideline or protocol in the clinic. Therefore, the antibiotic prescription rate was 34.5% prior to the protocol's initiation. In the post-implementation phase, 27 out of 40 or 67.5% charts demonstrated adherence to the algorithm, thus reducing the antibiotic prescription rate for acute bronchitis to 32.5%. The p-value of 0.5685 is greater than the significance level of 0.05. Therefore, there is not sufficient information to suggest a decrease in the ratio from pre- and post-implementation phase. Also, the achieved power of the study is 0.0709, which is considered low in strength, and a slight chance of detecting the study's true effect. Since there was no statistical difference between pre- and post-implementation data, the null hypothesis was not rejected. Moving on to limitations. There were some limitations to this scholarly project. First and foremost, the desired sample size for this project was at least 154 charts. The sample size consisted of a total of 69 charts, 40 charts from the implementation phase, and 29 from the post-implementation phase. Due to a small sample size, findings from this project jeopardized the accuracy and reliability of the data collected. Another limitation was a short intervention phase of the project. The project implementation phase was limited to 6 weeks as determined by the practice owner. The time frame of 6 weeks was considered minimal. A longer time frame would allow more data to be collected that would accurately measure and compare changes or decreases in the antibiotic prescription rates for acute bronchitis, potentially improving the effectiveness of the usage of acute bronchitis algorithm in decreasing the antibiotic prescription rates. Another limitation is Hawthorne effect. The Hawthorne effect is where the individuals modify their usual behaviors due to awareness of being observed. Clinicians may alter their documentation, or it may have caused a more adherence than expected in favor of the purpose of the study. Therefore, conducting a randomized double-blind study with a control group may help minimize the Hawthorne effect. Moving on to discussion. Although this scholarly project did not yield a significant reduction in antibiotic prescription rates, implementation of an evidence-based algorithm resulted in an improved antibiotic prescribing practice. Acute bronchitis algorithm could provide valuable data on patterns of antibiotic use and be reported at the level of the health system, the practice, and the individual provider to better inform and support antibiotic stewardship targets and initiatives. There is a need for ongoing antibiotic stewardship strategies in outpatient settings, including integration of CDSS into the clinician's workflow and the implementation of regular audit and feedback to monitor prescribing patterns and promote appropriate antibiotic use. Moving into implication for practice. Integrating clinical decision-making tools, improving antibiotic prescribing practices, and providing ongoing antibiotic stewardship education along with patient-focused educational materials are essential strategies. Continued advocacy for stewardship initiatives, participation in quality improvement projects, and the development of effective, equitable, and sustainable solutions are also critical to promoting appropriate antibiotic use. In conclusion, antibiotics play an integral role in treating bacterial infections, and preserving their usefulness is a priority. Antibiotic prescribing continues to be a growing issue worldwide. Practicing antibiotic stewardship helps mitigate this public health threat and remains the cornerstone of improving antibiotic prescriptions and its use. Study findings reinforce that one or a combination of strategies such as patient education, provider education, displaying public commitments such as providing brochures, posting posters in the exam rooms are some examples. Integrating clinical decision support system CDSS and performing audit and feedback can all help reduce unnecessary antibiotic use. This project highlighted the importance of continued education, adherence to evidence-based guidelines, and interdisciplinary collaboration in promoting appropriate antibiotic prescribing practice and improving patient outcomes. I would consider extending the timeline to at least 1 year to allow for more thorough implementation, sustained practice changes, and a more accurate evaluation of long-term outcomes. I plan to apply these findings in my clinical practice by supporting antibiotic stewardship initiatives and participating in quality improvement projects. The DNP program has strengthened my ability to critically appraise evidence and translate research into clinical practice. It has also enhanced my understanding of the importance of interdisciplinary collaboration and working effectively with the team members to achieve a shared goal. Additionally, I have gained insights into the various theoretical frameworks available and how to apply them appropriately in clinical practice. And here is a list of my references. And this concludes my presentation. Thank you for your time and your attention.